My name's Dan Steinfeld. I'm a respiratory physician at Peter MacCallum and Royal Melbourne Hospitals. It's my very distinct privilege to introduce our first speaker for the session. I don't think many people here need to be told who Mary Duffy is. Mary Duffy's our first speaker speaking on new directions in lung cancer survivorship. And this is something that Mary's been living and leading for over 25 years. For anyone who hasn't been working in the area, I'll give you a quick rundown on Mary's backstory and bio. So she's a clinical nurse consultant in the Lung Cancer Multidisciplinary Team at Peter MacCallum, where she's been for over 25 years. And certainly from my perspective, she has been a doyen and really sort of defined the role of lung cancer nurse care in Australia and internationally. She also, there couldn't be anyone better to talk about the lung cancer patient experience. She's been living that for even before that term was invented. So she's the perfect person to be talking about survivorship. She advocates for palliative care for patient groups she cares for, and has a close working relationship with all the palliative care teams as well as outside of the hospital in the local community. Mary begged me not to go through her portfolio of awards, but I will do that. She's the inaugural chairperson of Australia and New Zealand Lung Cancer Nurses Forum. She's a past co-chair of the International Thoracic Oncology Nurses Forum. She has received the IASLC Lectureship Award for Nurses and Allied Health. Many people will be aware in 2022 she was awarded the Order of Australia for her services to patient care and lung cancer. And in 2024 she received Special Recognition Award from the Global Lung Cancer Coalition. And still going in 2025 she was awarded the Lung Health Legend from the Lung Foundation of Australia. I could probably keep talking. Yes, well done, yes. I could continue talking about Mary and my talk would be longer than her actual presentation, so instead I will just hand over to Mary. Thank you, Mary.
Thanks very much, Dan. What a pity I didn't have a pause button on this to stop Dan way back. Thank you very much to the organising committee for giving me this opportunity to talk with you this morning about new directions in lung cancer survivorship, or as Sarin calls it, precision survivorship in lung cancer. So at the end of it, we'll see what we come up with. So what I'd like to talk to you about today is in the probably 10 minutes I've got, so I will be flying through this pretty fast talking. So stop me if you want to or talk to me afterwards. So we'll talk about a cancer survivorship model of care, how we established a nurse-led survivorship clinic in Peter Mac, where I work with my colleagues Mona Turker and Sarah McLean, fellow CNCs. And we've titled our survivorship clinic the Living Well and Beyond Lung Cancer Clinic, and we've abbreviated that. I'll talk a little bit about a case study of our first patient, and then we'll talk about key learnings and survivorship resources. Actually, I won't talk about that, I'll just show you the slides. So, cancer survivorship is a term that's not new in the cancer space. But in lung cancer it is, and certainly when I started my career in lung cancer, the notion of actually living to see a lung cancer survivorship clinic was something I never thought I would. So I'm very chuffed that we've been able to do that, and that's thanks to the scientists and clinicians in the room and the scientific trials that have allowed change the paradigm of lung cancer. The patients now live for a long period of time. And a person is considered a cancer survivor from the time of diagnosis, and this includes people having treatment, getting better after treatment, or having ongoing treatments. But we do need to acknowledge that the term cancer survivor does mean different things to different people. It means different things to the patients who are living the experience that we've heard from our patient advocates at this meeting, and also to the clinicians looking after them. And there are many things that are important for people who are actually surviving from any type of cancer, and in particular lung cancer. And there's varied reactions to people when they finish treatment. There's present with different side effects actually from their treatment. And they've also, of course, really importantly, the psychological issues. And I was very interested to hear the advocates, John, saying that we know they don't always tell the oncologists what the true story of what they're experiencing. And we as nurses, maybe arrogantly, think that we actually can get the truth out of them by asking questions in a different way than our very, very respect we have for our oncology colleagues who work beside us. And of course, surviving after a diagnosis of lung cancer impacts on all aspects of a person's life. It impacts on the relationships, it impacts on family, and it impacts on friends. And financial and other practical issues as well are touched by surviving cancer. And at Mask recently, a breast cancer survivor put up a very nice slide talking about we medicalise survivorship, we medicalise, make everything very clinical. But she talked about living after having cancer as a work life and a play life. And I didn't put that into my slide, but going forward, I think that's something that we need to think about, is actually about what it means for people living with after having a diagnosis of cancer and having cancer treatment. And survivorship care is care following the completion of adjuvant treatment. I'm sorry, I'm struggling to see my own slides here, so that's why I'm hesitating quite a bit. And the traditional models of follow-up are very much more medical-led and hospital-based. But there are other models of follow-up care that are important and acceptable both to the healthcare system and to the people we care for in it. And that can be shared care, it can be GP-led, or importantly, it can be nurse-led. And nurse-led survivorship models actually have been pioneered really through the Survivorship Cancer Centre in Petermac, and I'd like to acknowledge the wonderful help that my colleagues and I have got from particularly Nella Coombe and Michael Jefford's team there. And we know that nurses play a pivotal role in cancer survivorship, where we provide continuity and person-centred support across the care continuum. And specialist cancer nurses like myself and my colleagues are very well placed to lead this care because of our clinical expertise and holistic approach that we have to the people we look after. And so, importantly, nurse-led models achieve outcomes that are equivalent and in some cases actually better than specialist-led care, with potential cost savings to the healthcare system that we work in, but also to the patients and their families. And of course, now with being able to deliver some of these newer models of care in a not just face-to-face, but in a telehealth or phone model is both time saving for patients and their families and also financially saving for everybody involved. So setting up a survivorship clinic, of course, you can't do that alone. So we used practical tools, resources and evidence from the Survivorship Centre, and they're very happy to share those with anybody who's interested in them. And all of these resources are endorsed by the Cancer Nursing Society of Australia, which is important for us. So I'm going to step through now pretty quickly because of time, but the 4 steps that we took in achieving guideline structure and content for our nurse-led survivorship. Introduction and overview. So we're going to talk a little bit about cancer survivorship, models of survivorship care, and the benefits of nurse-led care. And to do that, we obviously set up a project team led and supported by many of our medical team members. And I think it's important for all of us who are ambitious, but to know that actually no one individual or no one craft group in a multidisciplinary team can make a change to systems. It takes a really great team, and involving everybody on the team from the conversations from the ground up are really important in the success or the failure of what we endeavour to do going forward. And delivering the clinic has been probably one of the biggest challenges and one of the we have peaks and flows in life about what matters most and what we're successful with. But sometimes, our clinic has been running for over a year, and some months we've been quite pessimistic that we were never going to get off the ground. But with a little bit of motivation and encouragement from those around us, we've kept going a year later. The three of us as lung cancer nurses, Mona's here in the audience, we actually believe that in 5 years' time we'll be able to come back to you with data that proves that we do make a difference to the people we look after. And of course, the important thing for the team is to know what the governance is, what the reporting and what the evaluation of our nurse-led clinic is, and importantly, how we link back into the team. So we don't sit separately from our multidisciplinary clinics. We actually chose to bring our nurse-led survivorship clinic into our standard clinic templates. So it's not an additional clinic, it's part of core business. So I mentioned about the team's approach, but importantly too, it's guided in evidence from work done by others, both here in Australia and overseas, and it's informed by the survivorship and follow-up guidelines, and really, really importantly, patient preference and experiences. And that's what I'd like to talk to you a little bit about in the 5 minutes I've got left. So, of course, we needed to work out what was the right thing to do. So with the assistance of the Survivorship Centre, we set up a very small research study to capture the lung cancer experiences and preferences, informing the development and implementation of our nurse-led survivorship clinic. And we developed some semi-structured interviews in a survey with close collaboration with a lung cancer survivor consumer representative. And interestingly, the consumer representative that was on our team was actually a survivor of a woman with small cell limited stage lung cancer, which is interesting coming from thinking of the last presentation. And that was marvellous to have her input into it, as well as members from our multidisciplinary team, respiratory physicians, radiation oncologists, medical oncologists, and some of our allied health, in addition to the Survivorship Centre. So we actually, us as lung cancer nurses, identified 26 patients, and of those, 20 were enrolled in our small study. And you can see the demographics of the patients there. And we chose to, we didn't aim to interview or include any of people with stage 4 lung cancer into this study or into this clinic, and I'll explain why as we go on. So pleasingly, patients were asked about what their experience was and what mattered most to them, and you can see some of the answers there on some of the slides. And we also wanted to know about what information and support they received regarding modifiable health behaviours, which in survivorship is really important. And we also wanted to know what were the concerns that resonated both for them and their families and their carers. Participants were also asked if the needs were considered and accommodated, and 47% indicated that the needs of their families were not fully provided for, which is very interesting, and that's something we need to build on going forward. And all the findings regarding the information and support received in the current follow-up highlight opportunities we believe to strengthen the education and support that we will provide in our new clinic. We asked patients, we have done some of this work before, we asked patients to explore their preferences for follow-up care. And we asked that for ourselves to know whether we were going to be successful or not, but also to help socialise the notion of the clinic in our multidisciplinary team, because that is really, really important. No surprise, consistent across the literature, monitoring for the cancer and side effects of the treatment was very high on the patient's needs. And we developed these into themes, and it was very nice to hear people saying they weren't expecting the side effects to be so many, and whereas we as clinicians think that that's what they know that they will get that. It was great to hear them saying that regular monitoring and follow-up helped ease any worries about the cancer coming back, and we know from our psychology colleagues that fear of cancer recurrence is the number one psychological fear that patients have. I'm just conscious of 3 minutes left. So patients were very positive about the patient experience. They acknowledged the value of allied health referrals and the hospital system and infrastructure. So we concluded that our lung cancer survivors value comprehensive survivorship care and support a nurse-led model. So that gave us the green light to come back to our team and say, this is what we'd like to do. And that's, so our clinic aim and objectives is to provide good survivorship care, which I think I've said it so many times, I'm not going to say it again. But we did develop a nice little flyer to give patients that explains to them who we are, what we hope to do, and it gives them something. So when we identify patients, we either give it to them in person or email it to them so that they know, and it gives them an opportunity, and we encourage them to come into our clinic with a list of questions. So the patient cohort that we are aiming to look after in our phase 1 of our survivorship clinic are a very select group. So it's patients after surgical resection, after SABR, or after chemo radiotherapy plus or minus durvalumab. So the early stage diseases is where we're starting. And we, as I said, we're going to do it in normal hours, either telehealth or in person. And so far, the people that we've had seen come through our clinic, we thought they would all prefer to have telehealth, but surprisingly, they have all chosen to come in person. Now, what that's about, I can't draw any conclusions, but it was just very interesting. So I do need to give a shout out to Peter Mack and to the nursing colleagues at work who could see this coming and were wise enough to put in an expression of interest to get one full EFT of lung CNC to aid Sarah and I, and we're very pleased to have Mona Turco join us as a McGrath Peter Mack specialist lung cancer CNC. So we had all this set up before we started the clinic. So we will also be able to attract a very small amount of funding, but funding is important for everybody in the exec and higher up level of where we work. And we also have got some validated survivorship training in terms of the VCCC survivorship modules, and also EVIQ do some training for nurses as well. And all three of us as a KPI have got a certificate from EVIQ on survivorship care. I'm not going to go through that. I'm sorry, I'm just going to go very quickly. So the first patient who came through our clinic, I obviously changed the name for confidentiality, came through a year ago. And I don't know which of us were more nervous, Lily or I, because it was my first time doing a face-to-face, very, very different nurse consult. You're usually going in, you go into people who are unwell, they're distressed, whatever, but this was a person who was well, and I didn't want to get it wrong. But it was a terrific experience for me, and she tells me it was for her as well. And number one up front, she said, fear of cancer recurrence, she had been living with for 6 years and continues to do so. But importantly, she felt much more confident after her cancer treatment than she ever did in her life. And it was lovely to hear her say that she had suffered with her mental health significantly throughout her cancer treatment, but that as a result of going into exercise, she now she does exercise 5 days a week, and going to the gym and her exercise is the best antidepressant I've ever had. So for me, that was beautiful to hear that language coming back, that actually there is a role for us as nurses in meeting these people, allowing them to tell us what's important to them. But importantly, we also take the opportunity. Lung cancer screening was starting at the time, and just being able to ensure that she was up to speed with her mammograms, her skin checks, but also we had a conversation about the importance for her in the future knowing about the lung cancer screening and what that would like. So tips for starting for those of you who are chomping at the bit to start a survivorship clinic, we would really say start small and go slow. And support is needed across the entire team. Ongoing communication, and I'd have to say that's probably something we did not do very well at all. We didn't socialise it continuously within our multidisciplinary team. But in this day, 2 weeks, Lou Irving is having a retreat for us all. We're going to start with a new agenda there in a new chapter and start to socialise it better within the team. So I apologise to the team members that we did not do that. And we're going to work with Nella and the survivorship team to work out how to collect priority data early. There's our resources. But this, lung cancer, we're all here because we love working in lung cancer. And some days are diamond days. And our team, had a wonderful diamond day in 2025 with one of our wonderful patients, friends, colleague. And I'd thank you very much, Lisa, for allowing us to share this survivorship celebration for a patient with stage 4 lung cancer. And many of you will remember that my colleague and psychologist Fiona gave a presentation 2 or 3 years ago about the important survivorship work we did called CAM, Cancer and Living Meaningfully, for the people with stage 4 lung cancer. And that will be phase 2 of our survivorship clinic. And hopefully we'll have many more great smiles like those that are there in front of you. So Sarin asked me to talk about precision survivorship. And I know that we're talking about shaping the future of thoracic oncology. But I think, like any nurse in the room, you have to make molds for what you're going to deliver in the future. And our molds for the future of survivorship care. I'd like to use the words of Michelle Obama, who reminded us when I went to see her a couple of months ago, don't be afraid to fail. And as lung cancer nurses, we found that out. And the power of using your voice, where you get your audience and how you use it, I think is really important. And the wise man of Michael Collins, who's one of our nurse practitioner palliative care colleagues, reminds us in setting up anything new, one size fits nobody. And I think that's a key message I'd like you all to take away. But, a bit like my brilliant career, I couldn't stop Dan, and you're going to have to try and stop me. But I have to say, as a lung cancer nurse, I think I've had a brilliant career looking after people with lung cancer in the Peter MacCallum Cancer Centre, and I hope that other cancer nurses go forward and have the same brilliant career that I have had. Thank you very much.
Thank you, Mary, for sharing that. That was incredible. Incredible to see how you've built something so substantial for the patients that until recently was really a neglected space. I think this session will run directly into the next session, so there may not be any opportunities for questions. If anyone would like to ask a question to Mary now, if you could approach the microphone.
Thanks, Mary, for the lovely talk. Do you use patient-reported outcome measures? Do the patients fill that in to inform the consultation?
I didn't go through that. So great question, Shalini. So the organisation is currently, in response to the great work done by Julia Laquan, looking at introducing PROMs. We don't standardly as yet, to answer your question. But we do use, for ours, we will use the modified version of the stress thermometer and the number of key things off that. Yeah, but great question. Yeah, we don't as yet.
Tight for time, so 2 more questions, please. Thank you.
Thanks, Mary. Always enjoy listening to you. You mentioned that you didn't include stage 4, and you were going to explain why you didn't.
So we didn't because we have, I guess we want to have, we've got some, we did our CAM work as a feasibility study, and we don't have any endorsed CAM therapists in Peter Mac at the moment. There's 2 of us waiting to get endorsed. And we had not done any survivorship work on the early stage lung cancer patients to start with, so that's why we started with the early stage. But John, by no means, I believe actually that the biggest volume of work we will do will be survivorship with the stage 4, and hopefully the work we do will be meaningful across, regardless of what stage of disease people have. But it's not absolutely, we will not leave anybody out.
And last question, thanks.
Hi Mary, Alison Collins from Austin Health. Thank you for your inspiring work. I just wondered if you could quickly expand on the rationale for waiting 12 months after follow-up to initiate.
After treatment, yeah, good question. So we had, we just were guided by what the evidence in the literature, and we chose 12 months after finishing. Yeah, some centres use 2 years. Some start. Actually, our radiotherapy nurse colleagues actually do a small amount of survivorship clinic work directly after finishing long courses of radiotherapy across all cancer types. So ours was arbitrary based on the literature.
The last question started perfectly to describe that as an inspiring talk, Mary. Thank you very much.